Hot avulsion may be effective as salvage treatment for focal Barrett's esophagus remaining after endoscopic therapy for dysplasia or early cancer. A preliminary study. Introduction. Endoscopic treatment for Barrett's esophagus, BE-related neoplasia is a well-established, safe, and effective treatment. Endoscopic resection of all visible lesions followed by radiofrequency ablation, RFA, of the remaining BE, columnar mucosa, to prevent the development of metachronous lesions is now considered the standard of care. Previous studies have shown that about 1/4 to 1/5 of the patients treated endoscopically are at risk of recurrent neoplasia if BE remains. To minimize this risk, most major society guidelines now recommend complete eradication of the BE mucosa. However, this can be technically difficult, as persistent foci of BE can remain after otherwise successful endoscopic treatment. Resection, repeat ablation, application of snare-tip coagulation, and argon plasma coagulation have been proposed. There are no reports on using hot avulsion to eradicate BE mucosa. Since 2010, the authors have been eradicating small, persistent BE areas less than or equal to 1 centimeter with hot avulsion using hot biopsy forceps, extrapolating from the success of this technique in removing non-lifting residual colonic polyp tissue after failure by snare excision. The aim of this study was to report the results of hot avulsion using a hot biopsy forceps to resect residual focal areas of BE. Background and study aims. Both endoscopic mucosal resection, EMR, and radiofrequency ablation, RFA, are used to treat Barrett's esophagus, BE, complicated by dysplasia and intramucosal cancer. However, focal areas of BE can remain after otherwise successful application of these techniques. The authors report the results of hot avulsion using a hot biopsy forceps to resect these residual focal areas. Patients and methods. This was a retrospective study from a prospective database in a tertiary reference center from August 2013 to May 2015. All included patients had undergone hot avulsion for eradication of residual focal areas of BE that were less than or equal to 1 centimeter and not suspicious for dysplasia following at least one previous endoscopic treatment for dysplasia or intramucosal cancer. Results. 35 patients harboring 124 residual areas of 1 to 7 millimeters were treated with hot avulsion. After a mean follow-up of 17.4 months, all patients achieved complete eradication of residual focal BE. One of the patients required a second hot avulsion treatment. Hot avulsion provided samples in all cases, but limited the assessment of dysplasia, cautery artifact, in 20.2% of them. The only complication was bleeding in 2 patients, which was easily stopped by soft coagulation. Conclusions. Hot avulsion appears to be effective and safe in removing focal BE less than or equal to 1 centimeter at its greatest length remaining after endoscopic treatment for dysplasia or early cancer. Further studies are required before this technique can be considered the standard of care.